next section, I have a kind of animated image for you where it's going to show you a sinus rhythm that is normal versus an AFib rhythm. So let's take a look at these two things. So obviously we have the SA and the AV, and you can see how this is very organized, right? And then it's transcending downward, and look at this hot mess over here. So I'm going to just kind of let that play for a second so you can look at how there's dysfunction and discoordination in the SA node firing and how that impacts everything else. So on this slide, we'll see some of the symptoms that are associated with AFib, and we're not going to spend a tremendous amount of time on this just because this is what you've seen this is what you saw when we were talking about myocardial infarction. It's the same gang of people here, right? We got fainting, dizziness, weakness, shortness of breath, chest pain. It's the exact same thing. So, but when you're filling out your pathomaps, you might want to put this down, and that way with your pathomap from myocardial infarction, you can look at it and put it side by side with your pathomap of AFib and see the similarities, but also see the differences, right? And that's what's important with this class is there's a lot of overlap, which is great because it's going to make you guys essentially see or understand the material a bit better and a bit faster, and you'll be able to tell some of the differences. So one of the major tools for, oh my goodness, sorry about that. One of the major tools for diagnosing AFib is the ECG or the EKG, and we're going to spend a bit of time talking about this today and kind of going over through some animations. When I asked you guys to watch the video last week, I was purposely vague because I wanted you just to get an idea of how this works, and I'm sure you already know what it is. But let's talk about how the EKG and the ECG, or this machine, using these electrodes, right, is going to create this pattern. And we're going to talk about how this pattern is going to change when we have a heart that isn't functioning correctly. So if we think about both AFib and myocardial infarction, both of them relied heavily on an ECG to kind of show irregular rhythms, or it showed how, one of these, as I said before on the earlier slide, we'll have a regular heart rate. And then if you look here, we'll have a regularity in the deflections, right? The upward and the downward deflection. We'll have irregularities in the QRS, right? This you can see here, I can't zoom in, but you can see there's some space between this upward and downward deflection. In AFib, this space will be narrowed a little bit. We'll talk about why that happens. Heart rate is changed, right? We could have an AFib 300 to 400 beats per minute. So what the ECG is going to do is essentially it's going to draw us a picture on graph paper of the electrical impulses that are traveling throughout the heart muscles. What's great about this is it's really kind of an electrical snapshot of the heart. And for people who have symptoms that might come and go, right? If we talked about intermittent bouts of AFib, right? Let me kind of go back here and just say, these individuals here, right? This would be easy to do an ECG or EKG on. But the people that are less persistent or people that are intermittent, right? Like these two here, it might be hard to capture those important ECG lines, especially if their AFib is not consistent nor chronic. So for people who have symptoms that come and go, we have a couple different types of monitors that are similar to the ECG machine that we would see in the clinical setting, but it's more transportable, right? We can kind of wear it and we can get measurements over maybe 7 days, right? Because if we talk about that persistent AFib, that is something where we're going to have to measure 7 days. And this ECG, this portable ECG with these leads, these electrodes, it can collect that data for us over the course of 7 days whenever we have a bout of that quivering, right? Or a bout of SA node misfiring. So we can capture these arrhythmias both in a clinical setting, or we can capture them using these kind of take-home monitors where we can get different type of information. And these are called Holter monitors. They also have something called portable event monitors, and they essentially do the same thing. They're just these small external recorders that are worn over a short period of time. Some can be 1 to 3 days, some can be 5 days. And basically, after the monitor is removed, a technician will look at all the electrical activity of your heart and be able to determine what is going on with the heart and with the rhythm, and determine if there is any AFib or arrhythmias. So let's talk about this. Okay. I had given this to you last week, and you guys watched a video, and I asked you to just basically understand what these waves are. And when we're talking about AFib, this P wave is going to be flattened, or, like I said, the heart quivers. It's going to look like the spaghetti that fell on the floor, right? When we talk about AFib, the QRS waves, or segment here, is going to be narrowed. So this space will be smaller, right? Repolarization will be affected by AFib as well. So we're gonna kind of go into how this is formed. I'm going to tell you about the mechanisms that form this on an ECG or EKG machine. We're going to talk about how this is in a normal heart, how this looks, or in a healthy heart, and then we're going to talk a little bit about how in a dysfunctional heart where we have discoordination, such as AFib, all of this is going to change. So just, again, basically, you watch the video, you know what this is. I'm going to read it just to beat a dead horse. It's, as I said, it's an electrical representation of what the heart's doing. It's printed on paper, right? So if you guys haven't seen it yet, I'm just letting you know that you can get a copy of this paper, right? The machine prints it out for you. It looks at how the cardiac muscles are contracting in response to this depolarization and repolarization, and it tells us what's going on, all right? So let's do a little bit of deep diving into some cellular physiology and talk about how this ECG works and how it functions and how we can interpret data from a healthy heart versus a unhealthy heart. So what I have for you guys here is some myocardium, right? So this is some of the contractile protein that is in the heart. I know it looks like bacon, but it is not bacon. We just have myocardium that is basically strung along, right? We know that it's cardiomyocytes because we have a single nuclei, right? We have this branching, right? We can see striation, so we know that there's contractile properties in there. And here we can see some of those gap junctions that I told you about when we were talking about myocardial infarction, right? And when I gave you the lecture on electrical impulses and contractile properties with the heart, and we know that these act like little tunnels, right? Which allows goods to flow through all the different cells in the cellular environment and to be shared. And these little tubes, these little tunnels per se, are going to be really important when we have an action potential and when we have depolarization and we have positive charge flooding into this tissue or into these cells, right? So we're going to talk about electrodes a little bit, and this is introducing you to how the ECG machine shows these deflections that determine how the heart is functioning, because this is remarkable science. So when we're looking here, I want you to imagine for a moment that I go into the myocardium, right? That's this fat muscle right here, and this is my scalpel, right? And I just chop up a piece of myocardium, and I lay it down, and it looks like bacon, right? So this is where I got that from, and I went in and I chopped out another piece, and I lay it down, and there's bacon, and we have two different strips here, two different strips of heart bacon. That sounds vile. This is what happens when you just are locked in your office and talking into a microphone by yourself at all times. You just kind of get some of these sidetracked conversations where you just talk to yourself and you think things are funny. Now, I want you to think for a second that I am going to put some electrodes here and here, right? So I have an electrode here and I have an electrode here. And what's an electrode? That's this right here, right? And then I put one here and I put one here. Well, one of these electrodes is positive and one of them is negative. And that's how these work here, right? We have some positive and we have some negative electrodes. And what we're going to do is, once I get these electrodes on here, I am going to stimulate depolarization in these heart muscle cells. Okay, so I'm gonna depolarize it. And you all know that when the heart is at rest, or when the neurons are at rest, or anything that is in excitable tissue, when it's at rest, what is the charge of that tissue? And I'm gonna sit quietly for a second and let you think about that. Let you go back to your basic physiology. And you should be saying, okay, well, most of these cells, most of these excitable tissues are going to be negatively charged. And when they're negatively charged, they have to reach a certain threshold. And then once they reach that threshold, they depolarize, right? So you guys remember that, right? So we're going to have this skeletal muscle, this cardiac muscle is going to be stimulated. It's going to depolarize, and then it's going to repolarize, which is essentially saying that it's going to get positive and then fire, right? It's going to depolarize. So we're going to have positive charges that are going to depolarize this, and we're going to get floods. We're going to get positive ions, which are going to flood into the cell and make this entire thing positive, right? So it's all negative in here right now, but once it fires, once we have a signal that tells it to fire, it's going to be flooded with ions, and then the whole thing is going to become positive, right? So when it becomes positive and these ions come in, they're going to use these tunnels to get to all the different cells. So that is how these cardiomyocytes, that's how they share these goods, right? And they're going to basically respond. So think for a second about the depolarization process, right? So these ions, such as potassium and calcium, they'll flood inside the cell, and they'll generate a positive flux of these positive charges, and then the inside of the cells become positive. And again, that's going to be shared with the other cells and the rest of the tissue through these gap junctions, these tunnels. Okay? All right, so I hope that makes sense. So now we're going to talk about the purpose of the electrodes, right? So we have a positive electrode here. We have a negative electrode here. And what these electrodes are doing is they're tracking the depolarization and the repolarization. But more importantly, they're also determining the direction of the repolarization and the depolarization. Okay, so let's say we have a negative charge. Okay, we have a negatively charged tissue. It hasn't been excited yet. And I took this heart bacon and I put it inside of a petri dish. And in the petri dish, we have an electrode on this side and an electrode on this side. And I want to stimulate an action potential. So I have the SA node up here, and I'm going to fire the SA node. And what's going to happen is I'm going to start it here. SA node's going to fire. SA node is going to tell the fibers to contract, but they can't do that until these cells flood with positive ions like potassium and calcium. And then that positive charge is going to go in this direction. So let's make this a bit more visual. Where's my there it is. Okay, so I start here. Oops, geez, I'm sorry. Let me make this a little bigger. I start here. I have the SA node fire. Okay. This is all negative right now. All right. I have a electrode here that's just like this. And I have electrode here that's just like this, right? So I'm creating this axis between this one and this one, right? And what's going to happen now is this tissue is going to be flooded with positive ions, and it's all going to become positive, right? So I'm going to draw a line like this, arrow, arrow, depolarization is happening, the propagation is happening, those calcium and potassium ions are traveling through here, right? And we are getting this positive movement of ions this way. And what's happening is, in this particular case, look at what direction they're heading towards. The positive charge in the signal is heading this way, away from the negative electrode and towards the positive electrode. And that's going to do something really cool if we have a ECG machine, right? If we have positive charge moving towards positive electrode, it's going to do something remarkable. So if we're measuring this on the ECG machine, we're going to see a certain type of deflection. And basically what this line is going to do is it's going to say, I'm a positive electrode. I'm sensing a positive signal coming towards me because the action potential started down here. The SA node fired. All the positive ions flowed through here, and it's heading towards this electrode. We get this really cool type of deflection that the machine is going to read and recognize, and it's going to go like this. Boop. Okay, what does that look like? That should look like something that you guys are familiar seeing since we started kind of doing this whole project. All right, now what happens if we move away from a positive electrode? Well, what's going to happen is, let's say we do this whole project again, right? Except I start down on this end, and I have the SA node here. Okay, and I fire the SA node, and we have depolarization, and all these positive ions rush into the tissue, right? Let me change this color so you can actually see that, what worked well there. Let's do pen. Oh, no, sorry. Let's do pen, and let's do yellow. That will probably work really well, right? So I fire it this way, and this just surges. We have a massive flux of positive ions, right? They're flooding through here. And what happens now is we have a positive charge moving this way. And class, what direction is that moving towards? Is it moving towards a positive electrode, or is it moving towards a negative electrode? And you can see that it's moving towards this. Okay, so when we have a positive charge moving away from a positive electrode, we get a really cool sort of deflection here. So what happens? What happens is we get one of these. Downward deflection. So if we have positive charges moving towards a positive electrode, we get an upward flexion. If we have a positive charge moving away from a positive electrode or towards a negative electrode, we get a downward deflection. And as you can see, that kind of sums up how all of this works. So let's go into it a bit deeper. So I hope that makes sense. So now we're going to talk about repolarization and how the ECG machine determines if something is repolarizing. So if we start talking about the repolarizing process, it's going to be the opposite of the depolarizing process. Okay, the cells that were made positive through depolarization are now going to have to regain that negative charge. So if we look at this piece of cardiac bacon here, and we were talking about the depolarization process, right? And it starts from the right to the left, and it's going away from the positive charges, right? So if we, let's say we are repolarizing. So let's say this was where the positive charge ended. And then we start moving this way, right? So the once positive cells are now starting to slowly repolarize, becoming more negative. So what happens then when we have, let's change this guy to pink, and let's change him to a pen. Or we'll do a pencil, whatever. So it was positive. Oh, that's horrible. That doesn't look good. Let me change it again. Let's do pink. It was positive, and now we are slowly becoming negative, right? All of this, these are negative signs. it's repolarizing, becoming negative once more. So if we have negative moving towards negative, we get no deflection. So we just kind of get this flat line here. Okay. So if we have, let's just go through it, positive moving towards positive, upward deflection. Positive moving towards negative, downward deflection. And then when we do repolarization, negative moving towards negative, we get no deflection. So the flow of negative charges towards a negative electrode gives us nothing. And we'll come back to this upright piece of bacon here. So let's kind of go through why all of this is relevant now and kind of discuss why I went through this with you. Okay, so when we put an electrode on somebody's chest, if we're trying to determine myocardial infarction or AFib, we have 12 leads that we usually put on somebody. And a lead, let me go back, these are leads or electrodes, right? We have 12 leads that we usually do. Number 2 lead is usually the most important lead. Well, they're all important, but number 2 plays an important role. So 2 out of 12 is pretty important. And what happens here is lead 2 usually starts up here on the arm and then usually ends down here on the leg. And how the electrodes work with that lead 2 is we get a negative electrode to a positive electrode, right? So now you're like saying, oh, I get it. Now he's talking about positive to negative and which direction the charges are going. So hopefully that is starting to make sense. So if we kind of just, let's cut out the heart here. Let's cut it out. And we just put the electrodes here, right? We can see negative and positive, and that's creating this, let's just leave the drawing out because I'm going to draw quite a bit. That's making this, axis from here to here, right? So when we monitor the electrical impulses with ECG, we are going to look from the top side down, okay? We're going to look from the top side down. So, and that makes sense, right? Because your action potentials are starting from the top and moving down, right? And we're going to start by looking at the SA node. So that's where we look from the top side down. Top side down. And we know that lead 2 goes from negative to positive. So, and I can put this here just to kind of help draw a better picture for you guys. Where is my shapes? Okay. So we can say lead 2. We have one that goes on the right arm, and then we have one that kind of comes down here on the left leg, and it creates this red axis that I'm showing you guys here, right? So that is how this electrode is going to read, which is why I showed you guys strips of bacon, right? Positive to negative or negative to positive, right? If we consider how this all works, we are going to look and we are going to start with the SA and the SA node and then the AV node. Okay, so we're going to generate the action potential that is going to fire, and that action potential is going to basically cross into both atria, and it's going to use that inner nodal pathway, okay? And then it's going to move to the AV node. So we have this guy here. He's going to fire. And we know when he fires, all of this tissue is going to become positive, right? And we know that that signal is going to be sent all around, right? Into the atrium here, down here, right? Over here, right? And once that signal fires, all of that tissue surrounding those electrical pulses are going to become positive. They're going to depolarize, and they're going to contract. Okay, so this means that the positively filled cells are depolarized, and they're going to stimulate contraction. And so momentarily, all the tissue surrounding the atrium, right, the left and the right, they are going to be positive. They're going to be flooded with those positive ions, which is going to make all of this internal environment positive. So if we think about the direction that it's going, right, it's kind of going out and down, out and down, out and down. And of course, the biggest signal, the biggest current is going to be this vector here, which is going from SA to AV. All right, does that make sense? And you should be thinking right now, it's like, okay, this is why he showed me that bacon. So basically what's going to happen here is the direction of the depolarization and the placement of the electrodes is going to, let's go back, right? Negative to positive. We have a positive current heading towards a positive electrode. Let's go back really quick. Okay, positive current. Which direction is it heading towards? Well, look at it's heading towards the positive electrode. So what is going to happen here? Well, what is going to happen is we are going to get our first deflection, and it's going to look like this. And now, ladies and gentlemen, we have our P wave. So when the SA node fires and all these cells are filled with positive ions, and those positive ions are traveling towards this positive electrode, right? And away from this negative electrode, we get our first deflection and we get that P wave. So our P wave is indicating the SA node fired and the tissue that it stimulates was filled with positive ions and it contracted, right? So this indicates that the atrial has been depolarized. All right. So in a healthy heart, we will have this upright deflection, kind of a small deflection, not a real big one, not as big as the R one. And let me draw that a little clearer. That's kind of ugly. Here we go. So we have this, right? We have this P wave, and that is demonstrating that the atrial has been depolarized, the SA node fired, and we have a current that went from negative to positive, right? So we have positive charges moving towards that positive electrode, and we have an upward deflection. All right, so let's talk about the next section. Here it is again. On this one, we're going to talk about the PR segment. So now the electrical activity has moved towards the AV node, right? And I kind of use this here to say that the AV node is active. We know that there's a delay in the AV node firing, right? It doesn't fire right away, so it allows these atrial to contract. So now the AV node has begun to be depolarized. And when it depolarizes, right, it's going to essentially fill this area here with positive charges. Okay. Now, it's going to depolarize, but it's going to maintain its electrical activity for just a little bit, right? It's not going to send that propagation right away because this guy's a bit of a procrastinator. And he wants to procrastinate because he doesn't want to fire while these things are still contracting. So that's why he has delayed himself. He hasn't moved towards an electrode yet. It's static. Okay. So now when it's static and there's been no further firing towards the positive or towards the negative electrode, then what we get is this section of no deflection. And it's going to look like let's get this one, this. All right, so that pause that comes after that first P wave. Oh, that's the wrong one. Let's change it. Let's change this guy. Pink and white. That comes after that first P wave, right? That is called the PR segment, and you can see that here, right? There's no deflection because the AV node hasn't sent the electrical impulse in any other direction. It's holding it so that this can contract and then relax, right? So we have no movement. We have the PR segment, which means this guy's just holding it. He's procrastinating. He hasn't fired anything yet. So we have a charge here, guys, but it's not moving towards a positive or a negative electrode, right? It's not going in any direction. It's just stagnant. So we have P, and then we have the PR segment, and you guys should be saying, oh, okay, well, the PR segment then is indicating that a positive charge is present, but it's not moving. And it's not moving because this guy is procrastinating. There's a delay, and I mentioned that in like every single lecture we've talked about thus far with the heart, okay? And that's why we have nothing happening there. All right, now the next location that this action potential is going to go. All right, we were here, we were talking about there's a delay, and that delay is represented by the PR segment. And then we are going to talk about where this action potential is going to go next. So the next spot it's going to go to is the bundles of His. And as you remember from our previous lecture, right, we're going to be looking at this section right here, is that the bundles of His dissect into two different descending branches, right? We have the right and we have the left. Okay, so and I indicated those branches here with those yellow lines. So this should be something that you should be familiar with. Oops, sorry about that. Now, you can see here that the charges are put on this side. Why did I put the charges kind of favoring this branch here? Well, it's because the left branch of the descending bundles, or the descending branch here, does most of the heavy lifting. All right, so when the AV node sends that message down, it doesn't share that message equally between the right and the left. It gives that message to the left, and then the left has to send it to the right. Okay, so I want you to look at what I have here. Let me change this color and use yellow. So this branch is going to be depolarized, it's going to be positive, and then it's going to send that message to the right. All right, so let's look at the direction of these arrows. All right, so we have the positive charge. It's going to come down and then go this way because it has to depolarize the right branch. So we have these positive charges kind of going that way. And now, is that way favoring the negative electrode, or is it favoring the positive electrode? So when these branches are propagating that signal, and eventually it's going to go to the Purkinje fibers, right? We could see, if you look at this big arrow here, it's moving away from the positive electrode, and it's kind of moving in a direction that's favoring this this negative electrode. So if we come over here, let me do this. This part of the, let me get a bigger one. This part of the propagation signal is going, let's look over here at this dude. It's going this way, right? And it's favoring this negative electrode. Now, it's not straight up. It's kind of out in this way. And this is how we are going to get our Q wave that goes down. Now, why is it going down? Well, let's go back over here and refresh. I told you when a positive charge is moving towards a negative electrode, there's a downward deflection. So that makes sense, right? So we now have our first downward deflection. Our initial deflection is the P wave, boop, right? And we know that's because positive is moving towards positive, right? The SA node is firing. It's sending that, let's go back here. It's sending that positive signal towards the AV node. So we get that initial P wave, right? And then once the AV node gets it, it's the procrastinator, it holds it, and we get nothing, right? And then, so let me draw let's beat a dead horse here. Let's change that to white. Let's keep the colors consistent. So we got this PR segment where there's nothing happening. And then the AV node says, hey man, I am going to now send this message to the bundles of His, and it's going to favor the left descending branch, and then the left descending branch has to send those positive charges to the right descending branch because this guy's lazy, he doesn't do anything. And if we have positive charges going towards the negative electrode, we get our Q wave. All right, isn't that cool? Isn't this insane how they discovered this? So that's how we get the P, the PR, and the Q. All right, because the majority of these charges are going towards in the direction of the negative charge or the negative electrode, right? So it's kind of going up here, and that's how these electrodes are. It's just fascinating to me how they figure that out. Okay, so Q waves are really kind of important with determining AFib issues. So what we'll see is when we have myocardial infarction or we have heart issues, Q waves can be altered. And that's all I really want you to know, because we're not going to be in the lab. We're not going to be talking about, I'm not going to have any like hard evidence because we can't put these electrodes on anybody. But in AFib, Q wave deflections can be altered. And the reason being is because, as I said, if there's a problem up here with the SA node, and the SA node is firing, and it's constantly communicating with the AV node, and the AV node is trying to pause, but it's like, hey, I can't pause because you keep sending erratic signals to me. I'm just going to fire. Well, now the bundles of His and the left descending branch is being bombarded with charges, and we're going to get different variations in this deflection, right? So just to recap, when we have AFib, sometimes we won't get a P wave at all. It won't be detectable. Or that P wave will, remember I said earlier, it'll look like spaghetti, right? Because of the quivering of the atrial, right? So that's why I'm showing you this, so that you can see and understand how the heart electrical pulses can tell the ECG what is going on and what it means physiologically, all right? And I'm just showing you here that these are some pretty big Q waves here, right? So here's a Q wave here, and look how different this Q wave is from this one. This one's barely present. So here we have a little baby Q wave. Here that Q wave is even smaller. Here there's barely any Q wave at all. Here there's absolutely no Q wave. So when we have these complications in the heart, the machine will tell us, and it will tell us where it's happening, right? So that's why this is such an awesome piece of equipment. And you guys as exercise physiologists, you need to know this. You need to understand how the physiology is communicating with the machine. And you're like, oh, I get it. The Q wave's messed up. It doesn't look normal. So that means something is going on here. All right. Let's move to the bundles of His. And let's move to the Purkinje fibers as well. So now we talked about how the AV sent its signal to the left descending branch. The left descending branch was depolarized, and then it had to resend that signal. Let me change the color in this direction. And we know that's moving away from the positive charge electrode. And it's basically stimulating this negative electrode, which is telling the deflection to go downwards. Okay, so now we are going to get into the ventricular contractions. So once the branches send that signal down to the myocardium down here, right, these thick contracting muscles, now we're getting into ventricular contraction. All right, so if there was a problem up here, there's going to be a problem down here. All right, So the signal is being received from the bundles of His and from the left and right descending branches, okay? And it's going to start to propagate the Purkinje fibers, which are on basically the left and the right side, right? So we know that this makes like this netting that kind of surrounds the entirety of our myocardial here. Now, in this section here, you can see that I put a bunch of arrows showing different directions, right? So how does the ECG make sense of positive charges that are moving this way, this way, this way, this way, this way, this way, right? Because these are small little networks here. So this entire muscle has to be stimulated by depolarization of the contracting cardiomyocytes, and it's kind of going out in various directions. So this is where the machine is super, super, super smart. So I want you to look at the difference that I have here in positive charges here and positive charges here. And we can see that there's more of them here. Now, why is that? Well, because the left ventricle is meant to be the biggest, strongest muscle in the heart. I mean, look at the size difference between the left side myocardial and the little baby skinny one right here, right? This is a bigger muscle. So what does that mean? Well, it contains more muscle cells. It contains more cardiac muscle cells, right? So just by sheer volume, it's going to have more positive charges because there's more cells, right? There's going to be more activation and more positive ions circulating through those cells than on this little baby side here, right? So this yellow thing is kind of showing the direction. If we took a mean value of all of this, it's kind of showing the direction of the charge. All right. So now, how does the machine then determine which way to make a deflection? It's going to identify that the ventricles are producing the largest signal for deflection. And of course, as we all know, the left ventricles are going to push out all of that blood into the rest of the physiology, right? So what's going to happen here is we are going to get a massive surge, which is your R wave, right? Because this is depolarizing this section here is depolarizing the Purkinje fibers. The Purkinje fibers are firing, and we have a massive contraction. So basically, since the majority of this signal is going this way, it's kind of favoring the positive charge, or the positive electrode. Now, once this fires and it contracts and it becomes positive, we are going to get, let's change this, we're going to get, let's go green, we are going to get this massive spike here. So the R wave is representative of the myocardium being stimulated to contract by the Purkinje fibers, and blood being ejected outward. And that's why this one is so massive, because it's such a big, forceful contraction, and there's so much positive movement here, and it's kind of heading down towards this electrode, right? So we know when positive heads towards positive, we have a deflection up. All right, so the R wave is representing the ventricle contraction, but it's representing, let me clear this up, it's representing, let me clean this up a little bit, it's representing more of this medial area. So let me get a different, let's highlight this, let's do this color. It's representing more of this medial area, right? So I want you to say that the R wave is representing medial ventricular contraction. And you're like, well, what the hell does that mean? Well, we have medial, okay, and then we have base. So your base is going to be up here, and we'll talk about that on the next slide, right? Medial and base, because as you know, those Purkinje fibers, they go all the way up, right? They follow the myocardium all the way up until it gets to where this atrial starts. All right. So R wave is going to be the medial ventricular contraction, and if we just kind of go back and say, okay, well, we started with the P wave. Oh, I'm sorry, P was pink. Let me erase that. We started with the P wave. P was pink. Boop. Atrial firing, atrial contraction. Then we had the PR segment, and that was PR segment was, hey man, the AV has the message. It's holding it. It's delaying. It's a little bit on the lazy side. There's no movement. And then we said that the AV sends the message down to the bundles of His, and then the left branch takes the majority of the heavy load, and it has to propagate that signal over here to the right branch. That makes that current kind of move in this direction. And we know when a positive charge heads towards a negative electrode, we get a boop downward movement, which is the Q. And then once we have the depolarization here and here, that's going to move next to the Purkinje fibers. And then these green arrows represent all of that positive activity happening there. And then boom, the left ventricle contracts. And we have this massive spike here. And we know that it's the left ventricle because it's the bigger muscle, right? Than the right ventricle. It's so much smaller. It's going to have more positive activity here. We're going to have a massive spike in that ventricle activity here. And that's going to be indicated by the R wave. All right, gang, we are almost done with the physiology here. So let's just go through a couple more things. So on the R wave, we talked about base contraction, and I have this here in this color here. Let me erase that. Let me just start it all over again because I don't like when I don't show you guys things in real time. So we're talking about base contraction, right? And we're talking about these big muscles, a lot of electrical activity, a lot of positive ions in there, right? And that makes this guy just boom, right? It goes really high. And then we're going to get to the base, right? And here's the base. All right. Now with these base fibers, we're going to have, there's not many of them, right? Most of those cardiomyocytes that are contracting are here, right? And the bundle of His, it's sending that current here, that electrical impulse. It's sending that current here, right? We know that it's all positive. And then it's going up until this area here, right? It's propagating up to here. And what happens is we have the positive charges here, right? There they are. And let me ask you guys, what direction are they going? And if you remember, let's go back to our bacon. If we have a positive charge heading towards a negative electrode, what deflection do we get? Downward, right? So that kind of makes sense, right? So we have positive charges heading towards a negative electrode, and we should get a downward deflection, right? So now we get boop, S wave. Okay? So should we recap? Should we beat a dead horse? Let's do it. SA node fires, atrials contract, P wave. Then the AV node gets the signal and it holds onto it, and we got like a whole lot of nothing because it wants to make sure that the atrial is done firing. Then what happens is the AV node sends that message to the bundles of His and then the descending branches. And we know that the left guy is a hard worker, the right guy is lazy. So the left guy has to get those positive signals. I'm trying to drive pluses here with my keyboard thing. Okay. And then it's got to send them that way. Right. And we know when we have positive charges heading towards a negative electrode, we're going to have a drop. Right. There's that Q wave. And then once we get the left and right descending branches begin to activate all the Purkinje fibers, we get that base ventricular contraction, right? Goes up really high. And then following that base ventricular contraction, the medial ventricular contraction, then we get the base ventricular contraction. And since let me just kind of clean this up a little bit so I don't confuse you with straight lines. When we get the base contraction, we see that that positive movement is heading back up towards this guy, which is going to give us a negative deflection. All right, so it should be making total sense by now. And then let's look at the last few segments here. So now we have the ST segment. And the ST segment, which is here, is a isometric line. Isoelectric line, right? Just like we saw here with the PR wave. And let me just kind of move some of these things so we don't confuse you guys. Let's get rid of these charts. Oops, can I get rid of it? Oh, wrong one. Sorry about that. Get rid of you. Get rid of you. Get rid of you. Get rid of. Not the heart. We want to keep. Oh my gosh, the heart's just trying to move over. Let's get rid of some of this. Clean it up a bit. So what exactly is the ST segment signifying? Well, we still have the negative, we still have the positive, right? We have these charges. It's following this electrode line here. When we get into the ST segment, there's no net movements of any positive charges. There's another pause. And this is one of the most important lines when it comes to pathologies of the heart. So I believe in the myocardial infarction lection, I mentioned the ST segment, and that we are going to kind of need to focus on that with the EKGs when it comes to irregularities of contraction and electrical impulses. So here we have no net movement of charges because we are about to start repolarizing. All right, so that kind of indicates that the cardiac cycle is almost done. And now we're going to repolarize. So we have in this ST segment here, we've just recovered from the base ventricular contraction. And now we have this ST section where we have an isoelectric line. We have no more positive and negative movement of charges in the cell. And then we're going to go to the T segment, which is going to be repolarization. So now everything that we did with the positive charges has to become negative. So you can see this negative stuff here, right? The negative charges are going to start moving this way and this way, and the entire heart is repolarizing, and we get this big movement of negative charges moving towards what? Negative electrode. So what happens? Should we go back? So I just want to move back to this slide really quick, and I apologize if there was any confusion. I have been interrupted so many times today with phone calls and meetings and emails that I am losing my mind. So earlier in the lecture, I had mentioned that when we have repolarization, right? So let's just say, I just want to make this clear so I'm 100% clear. Let's just say that all of the positive charges are on this side of the muscle, right? And it recently depolarized and it recently became filled with all these positive charges, and now we're going to repolarize. So what happens now is all the positive stuff that was kind of over here is going to start moving backwards, and we're going to start to get repolarization going this way. Okay, so these little lines are representing negative charge, right? So everything inside the cell, everything inside the heart is negative, and it's moving in this direction. So where is the negative charge moving towards? Well, it's moving towards the negative electron and that electrode. And earlier I said that's a flat line and no deflection, but that's not true. It's a positive upward deflection. So the reason I'm trying to show you that is, and I put notes in there where I made the mistake. The reason I'm showing you that is because when we get to the T wave here, the reason we have this spike here is because, let me just erase all this and clean it up. I want to make sure we're 100% clear, is because just like what I showed you previously, like we had all this positive stuff here, and now the positive stuff is going to repolarize, which means it's going to become more negative, and it's going to start moving upward towards what? This electrode, sorry, not electron. So what's going to happen there is we have the negative charge moving towards the negative electrode, and we're going to get this little spike here, which is the T wave, right? So if I were to ask you, what is the T wave, you're going to say, oh, well, that's easy. That's depolarization of almost the entirety of the heart, more specifically the ventricles, because the ventricles just contracted. And that repolarization is basically going to start from the base, then it's going to move into the medial part, and then up the septum and towards this electrode, right? We know that this electrode up here is negative. So now that negative charge is moving towards the negative electrode, right? So the heart's here, it's moving this way, and we're going to get that little spike. So I just wanted to make that clear, and I'm so sorry if I am confusing you guys. It has been a very rough day with trying to get this thing recorded in peace. Okay, so now we are going to, let's move forward. So we can have, as I mentioned earlier, we can have heart rate be determined by the RR interval, right? So we can have bradycardia or tachycardia, and this just means that the heart rate is slower than normal. This means that the heartbeat is greater than normal, 100 beats per minute, and then our normal heart rate is basically within the 60 to 100 beats per minute. So how can we basically determine heart rate? Let me go back. I apologize for that. Well, we can look at the RR intervals. So we look at the R segment and look at the R segment, and we look at the space between. So here we can see a lot of space between the R and the R. So we can say that this is indicative of the bradycardia, which is the slower heartbeat, right? And then we can look at something that is like this. Look at how frequent these R's are. R wave, R wave, R wave, or R segment. And we can say that is very frequent. So that might be something that is indicative of the tachycardia. So those are both different than normal heart rate. So again, if I said to you guys, what can we use the R waves for? You could say, well, it represents ventricular contraction, at least the medial part of the ventricular contractions, we could use it to determine heart rate. And I'd say, okay, well, how do you determine heart rate? Well, we use the RR interval, so we look at the space between the R's, and I say, yeah, wonderful, you did a great job. And then here's another example of that. You can look at this at your own time. It's basically showing you. I put some little arrows in here just to kind of show you the same thing, right? Slow versus irregular. And this is the guy that we see in AFib, this kind of irregular. Let me erase what I just did there because that's kind of messy. We kind of see that this poor soul that is dealing with AFib, we have a R wave here, an R wave here, and then we have a real long space in between, and then another long space, and it almost seems like from here to here it normalizes, but in this guy here we have some irregular R waves. All right, so let me just let me get rid of this. Why is that not working nicely? It's not playing nicely. There we go. So I just circled that so you can see the irregular R wave. So that you can do, look at on your own time. Now, I also have two slides here, which I have explained everything to you guys in detail, but this is just talking about how the P wave changes, and we've talked about that, so now I'm just reinforcing that. So you can look at that, and then I also gave you guys a video here that you can use to start looking at some of these animations. These animations are really important, so please follow this link and watch that video. Now we're going to get into exercise, and what I'm going to do for you guys is I'm only going to go through these last 3 slides with you, all right? Which means you have slide 33 to 39 to look at on your own. And the reason I'm having you do that is because as we get further into the program here, I'm going to start taking off the training wheels a little more and, leave you to ride your bicycle on your own. So let's just quickly go through how we would do exercise testing with somebody that has AFib. And then you guys are going to need to know some of this stuff for your quiz. All right. So there's a couple slides, and if you guys have any questions, you can certainly ask me. But what I want to focus on are these. So if we're going to do exercise testing with somebody that is living with AFib, how do we test them in a manner where we're not going to basically kill them, right? Because if they already have a heart that is stressed out, we are going to stress them more with exercise. So when we're going to test, if we're going to test the aerobic system, we're going to do cycle or treadmill. We're going to do moderate increases or increments in increase capacity here. And you can see the watts and you can see the 3-minute stages, right? Treadmill, same thing, individual ramp protocol, 8 to 12 minutes target. So we have a time frame here and we have watts. When we do this protocol, when we do any of these, we want to have a 12-lead ECG that measures heart rate as well. And I walked you guys through all of that, right? So we're going to measure heart rate and we're going to measure heart activity. Oh my goodness, why is it doing that? We are going to measure blood pressure, right? We are going to ask about rate of perceived exertion. We're not going to worry about this scale. And we would like to do a VO2 gas analysis test. We will not do radionucleotide testing. So let me get rid of some of these for you guys here. Okay, so we are going to not worry about this. And we are not going to worry about this. Okay, so what I will do for you guys in the up and coming lecture is I will basically tell you what this watts looks like, or what this would, let me clean that up, sorry about that. I'm trying to draw on my trackpad here and it's not, I'm left-handed but I'm using my right hand, so let me try this might be cleaner. We will talk about what that looks like, and we will talk about what this 20 to 30 minute stage protocol looks like as well. And then we can give you an indication as also how this ramp protocol works. Basically, the takeaway that I want you to have here is that, okay, we can test somebody. If we're going to do it, we're going to do it on a cycle or we're going to do it on a treadmill. And what's going to matter here is that the watts are at a pace where the intensity is not going to be too hard. And again, the takeaway message here is when we do test these individuals, we have to monitor these things. And that's why I went through so much on the ECG with you guys today. We have to monitor blood pressure because these measurements, ladies and gentlemen, is going to tell us when we need to stop the protocol. Okay? So if we have a 12-lead ECG while somebody is on a cycle and we see severe dysrhythmias, well, that means that we're going to see things possibly, let me clean this up, like this, right? We're going to see major irregularities in R waves, in P waves, in Q waves, right? And if you want to know what that looks like a little more, you're going to go back to this slide and we're going to look at, okay, here's a normal P wave. Here is the spaghetti P waves that we see with somebody with AFib. So this would be a severe dysrhythmia or a complication that is causing the quivering or the unorganization of the heart beating together, right? So that now I'm trying to put all these things together for you guys here. We're going to look at changes in the ST segment. Now, we're not in the lab, so it's really hard to kind of show you some of these things, but I will provide you with another small article talking about that. I don't want to do it today because I'm just bombarding you with so much information. So if I said, okay, guys, what might we see with somebody with AFib? You're going to say, oh, we'll see severe dysrhythmias, and we'll see some changes here. And why will we see some changes there? Well, because I told you that when we have a AFib condition, we don't have synchronization between contraction, contraction, relaxation, and then contraction, contraction, relaxation in the ventricles. It's not uniform. So I told you when we're at this ST segment, and it's basically showing us that nothing should be happening because we're about to repolarize, what we would see in somebody with AFib might be something like this. Right? There might be changes in that ST department there because, again, this thing is not, this heart, this unit is not functioning together. So where we should have this isoelectric line where there's no activity, we got this kind of spaghetti chaos there, okay? So we can see changes in the P wave where it could be absent or it could be spaghetti. We have changes in the ST segment where it should be isoelectric, but we see some activity, okay? So you see how this is all coming together right now? So this is saying it could be a 2 millimeter depression or elevation. And the reason I'm just making it easier for you guys is I'm just saying, where's that one at that I just did? There it is. I'm just saying, okay, this is signifying that 2 millimeter depression. It's basically spaghetti, okay? So basically it's not looking how it should, nor is the P wave looking how it should, okay? So that's what that 2 mm depression or elevation means. It just means, hey, it's spaghetti when it should be isoelectric, okay? Ischemic threshold, so we're going to look at oxygen saturation. Are we fully oxygenated? T wave inversions, okay? So really quick, let's go back to that. Let me clean this up for you so we have clean lines here. So a T-wave inversion would look like this, whoop, right? And that means that the repolarization process is not occurring the right way, right? So it tells us, and again, I just want you guys to think about big pictures here, right? Like big concepts. If this is inverted and it's going the wrong way, that means that I told you this is repolarization. Something is not right in the repolarization process. So let me clean this up. So that means that the negative charges aren't going back towards this electrode and we're having issues with repolarizing, right? So that's it. That's the big ticket takeaway from that. And if we have systolic blood pressure above 250 and diastolic above 115, that means we need to cut the measurements because now we're really stressing the heart. Okay. Now we could also, if we don't want to do an assessment using these types of apparatus, let's say we just don't have them. Let's say we're not working at a hospital. I don't have access to these things. I don't have a 12-lead ECG. I don't have this data to look at to determine if I'm stressing them. Well, then we can do a 6-minute walk test. And during the 6-minute walk test, we just measure the distance walked. And we allow for them to have some rest, and we just note how many stops and rests that they take, and we record that, right? So we're just getting data about how well they can do on this test. And I will, just in case you don't remember what a 6-minute walk test is from 456A, I will give you the protocol on that to refresh your memory. I'm not going to do it today because I do not want to stress you out with all this information coming at you. I will slowly introduce it to you. So all I want you to take from this is, yes, we can do this in a clinical setting. We can measure, we can do exercise testing to determine how bad their AFib is. We can use a cycle. We can use a treadmill. We can, if we're going to use these two things primarily, we could do a 12-lead ECG. We could take blood pressure. We can also do rate of perceived exertion, and we can do this oxygen exchange. So this is, we would like to do all of these things together. This is what a stress test is, right? And then we have these really important endpoints. And then we talk about like what these waves will look like with changes in ECG. Or we could just do a walk test. And as I said, I'll get that to you. We're not going to worry about flexibility. Here's some special considerations to keep in mind. Again, we're not going to worry about medications. There's too much coming at you in this class already. So please don't worry about that. I just put this in here so you guys can look at some of these things and keep them in mind. And then if we're going to do AFib exercise programming, here is what we can do. I have it all summed up for a nice package for you guys. So yes, we can do aerobic training. Yes, we can do strength training. Yes, we can do flexibility training. The goals of aerobic training is we are going to increase VO2 peak. I think we can do it by about 20% with people with AFib. We're also going to want to increase activities of daily living. So if somebody has AFib, just getting off the couch and walking to the refrigerator might be difficult. So when we want to, as the more we exercise, the more we increase the VO2 peak or our VO2 capacity, the more things they can do in their daily activities. So when we talk about volume, right, exercise frequency and duration, we want to have a rate of perceived exertion about 11 to 16. 20 is reaching, it's stretching it. VO2 of about 50 to 80%. So what would that look like? I'm sorry, let me restate that. Not 50 to 80%. 50 to 80% of their VO2 peak. So let's say that they scored, what would somebody with AFib score? Well, I guess we could say somebody with AFib would probably score around 20. Sorry, that's a horrible 20. As again, I'm writing with my right hand and I'm left-handed here because I'm using a trackpad. About 20 to 30. So what would 50% of, let's say, 25 be? Or what would 50% of 20 be? So we would want them to exercise at somewhere at about 10% or a VO2 of 10, right? We would want them to exercise 3 to 5 days a week, 30 to 45 minute sessions. All right, so really, really light exercise. And then if we wanted to do them strength training, we could do strength training, high reps, low resistance, 3 days a week, about 2 to 3 months. And then flexibility, I'm not going to worry about too much, just because, like I said, we got so much coming at you guys. Okay, so here's what I am going to do, and I'm taking note of it right now. Let me clean this. Oh, that's not what I wanted. Let me clean this up. Here is what I'm going to start getting into your hands. So we talked about how to measure and why to measure, and then how to prescribe exercise based upon those measurements. So what I'm going to get you is I'm going to get you a protocol for this, and we are going to talk about it. I'm not going to worry about this scale. I'm not going to worry about radionucleotide. Okay, this you got. This you should understand. I will also start to get you some of these protocols so that you understand the time and the intensity. Same thing with this here. We will start talking about what a VO2 peak is. And I'm kind of putting the cart before the horse here, but as you can tell, some of these lectures are pretty intense, and I got to get you the basic information first, or this is going to be a 4-hour lecture. And I don't want to do that to you guys, okay? So let me clean this up. So the other thing I'm going to get you, and then we're going to start talking about, is what is a VO2 peak? And I will make a small little lecture on what that is. And what is 50% or 80% of a VO2 peak? And what is heart rate reserve? So these things I'm going to start getting to you, but in slower increments, because you're going to see throughout this entire textbook, it's going to be very similar. Heart rate reserved, 50% of VO2 peak. So even though the book is talking about it right now, I can't put all these things in your hands at one time, but I will start getting them to you. So this concludes the lecture. Your only thing that you have to do is I'm going to ask you to look at this, slide 33, look at this, look at this, look at this, and this. So like I said, I am taking some of the training wheels off, and I'm going to ask you to start looking at some of these slides by yourself. I will do the heavy lifting and present you guys with some of this, some of these slides here. And I do apologize for that mistake that I made, and I did fix that in that last slide. But that's all I have for you guys. I'm going to get this video uploaded and get it to you guys, and I hope you guys have a wonderful day, and I'm going to stop talking because I've been speaking since 7:30 this morning, and it's now 4:16. Take care. I will be in touch.